I'm Robert Mittman, and I am the panel facilitator. The series as a whole is designed to look at various aspects of the impact of genetics on human health. So looking at the organization and funding of research, looking at the information infrastructure in healthcare and the management of intellectual property that derives from genetic research were the first two panels. This panel is going to be focused on the economics of health and how that interacts with genetics. And then a final panel that begins at 3:30 that's focused on policy, regulation, and public confidence. Let me introduce both the process and the content for this panel. This series is really designed to be quite interactive and conversational. You will see almost no PowerPoints. It's not about a series of long PowerPoint presentations, but rather what I hope will be an interesting conversation among our panelists and eventually among you in the audience. I'll be circulating with a wireless handheld, so as the session develops, please store up your comments and questions for the end. Before I dive into content, I would like to acknowledge our sponsors and conveners. First, from the AAAS, Barbara Jasny, and she's been instrumental in organizing and bringing together the panels. And from Affymetrix, Katie Buck, again, who has been just essential on really pulling both the content and the groups of panelists together. This panel is interesting and will be wide-ranging. Let me maybe begin by introducing the panelists and then the content a little bit. On your left is Jan Karlstedt-Duke. Jan is the director of research at the Karolinska Institute in Sweden. He'll say a little bit more by way of introduction when it comes time to turn to the panel. In the middle is Richard Jackson. Richard is a researcher at the Center for Strategic and International Studies. CSIS is very wide-ranging in its research interests, but Richard's particular specialty is on demographics, and particularly globally the demographics of aging. And then on the far right, on the other end, is Michael Caldwell. Michael is with the Marshfield Clinic, which is located in Wisconsin, and is a stronghold of innovation in the clinical practice of medicine, its documentation and use of information technology, and increasingly in linking the large clinical databases that it has with genetic research for fascinating research purposes. And Michael will say a little bit more about that as well. This panel, as I said, is about the economics of health and healthcare and how it pertains to genetics. What I imagine for the conceptual shape of this panel is a bit of a funnel, where we're starting from the broadest and the longest term, thinking about the changes in the population here in the United States and globally, and asking the question, what are those demographics? We obviously have read a lot about them, and it's no surprise the aging of the population. But then, what is the impact of that on our health and our health economy? And how does technology, including genetic technologies, play into that economic equation with the aging of the population? So that's an initial, broad, long-term point of view. The next two points of view, I would say, are rather than conversations about the future, or points of view about the future, they're almost points of view from the future. Sweden, its demographics are much further along the curve on the aging of the population, and it has confronted, to an extent that we haven't yet in the United States, the social responsibility for the health of its population. They've made some different choices, and some of those choices, I think, are reflective of choices we may make in the future, and so you can think of that view as a view from the future. And the marsh field is, I think, reflective of a way that medicine will be practiced in America, and a relationship between the practice of medicine, the clinical practice of medicine, and clinical research, again, that is reflective of some things that we may see in the future. So that, in a nutshell, is our flow. Broad view analytically, two views arguably from the future. Now, it's very much the case, and you as an audience, I think, need to know where each of the panelists stands. It's very much the case that where you stand depends a lot on where you sit. And so I'm going to ask each of the panelists to introduce himself briefly so you know a little bit better where each of them is coming from, and as they express points of view, really what is behind that. And Jan, maybe I can ask you to begin.
Okay, so it's a pleasure to be here, and I feel like the odd man out here, but I'm the Dean of Research at the Karolinska Institute, and one of the biggest tasks that we have is to try to utilize the fantastic resource and possibility that we have in the form of a socialized health service to actively work with these issues that have been taken up. So in a socialized health service, what it means is you have a health service that is available for the whole population. It means that you can really do population-based studies and analyze a lot of the factors that affect the way we offer and perform health care. And the resources that we have for that, and something that we've been very actively developing during the recent years, is registers based on the patients, the population that can be followed up in a long-term basis. And the more recent ones are quality registers, specific registers that focus on different diseases to give us the information that can then be utilized to understand how we should work with the various diseases, and to integrate this data with other types of information.
Thanks. Richard?
Yes, I direct the program at the Center for Strategic and International
Could you click your mic on, please?
There we go. A program at CSIS called the Global Aging Initiative. We look at the long-term fiscal, economic, social, and even geopolitical implications of the aging of the population in the United States and around the world. Healthcare, of course, is a big part of the aging equation. Healthcare sort of impinges on my world because it has a big impact on fiscal costs, the sustainability of retirement systems, future tax rates, future living standards in the first place. And in the second place, because the future health of the elderly is crucial to understanding possible responses and solutions to the aging of the population. There's sort of a good news and a bad news joke, right? The good news is we're all going to live into 120. The bad news is that we're going to have to work to 110. Well, can we? And how much? And will we have to spend all our money on doctors? So, I'm not an expert on genetic medicine, but I do know something about aging and health, and that's the perspective I bring to this.
Great, thanks. Michael?
I'm a general and vascular surgeon, so I look at this from a lot of the pragmatics of the healthcare perspective. I work in a large group practice, about 750 physicians, all in one group practice that provide health care to much of the state of Wisconsin. And do that through a very highly integrated system. And as you will see, I'm one of the renegade PowerPointers, but am of the belief that we can use the data that are generated in that process to begin to predict the outcomes for patients in the future, and hopefully avoid some of the cost that we will hear talked about earlier. And we've founded a population-based genetic study called a Personalized Medicine Research Project to begin to define those terms properly.
Good, thank you. Richard, let me start with you for that broader, more comprehensive point of view. And you know, before I took my current work, I worked for almost 18 years at the Institute for the Future, and for all of that time, we talked about the aging of the baby boom and the impending, you name the crisis, but retirement and medical were always featured prominently. Can you give us just some sense of magnitude, timing, and impact of these aging trends, both in the U.S. and abroad?
Well, I mean, I've been saying since the mid-1980s that we have a narrow window of opportunity to prepare for the aging of the population. But I guess you can't really have a presentation if you don't have a window of opportunity. So I've kept the window of opportunity. The whole world is aging, and the developed countries are leading the way. For most of human history, the elderly comprised a tiny fraction of the population, never more than 3 or 4% in any country. That share began to rise during the Industrial Revolution. It now stands in large part due to progress in public health. It now stands at about 15% of the population in the developed countries, and it's headed for 30% by the 2030s, and that's just the average. In some fast-aging countries in continental Europe and in Japan, the elder share could be shooting past 35%. Graying means paying. It means, that's my Jesse Jackson line. It means, graying means paying. It means paying more for pensions, more for health care, more for hospitals, more for doctors, more for nursing homes, more for social services for the elderly. CSIS projects that overall, what governments in the 12 largest developed countries on average spend on public benefits to the elderly will rise from 12.5% of GDP today to 25% by the year 2040. Elderly is here defined as 60 and over, not because 60 and over is necessarily the threshold of functional senescence, but because it is the typical age of access to publicly subsidized retirement benefits in most countries. Now, in the United States, the cost projections are somewhat less daunting. The elder share, the share of GDP that government spends on the elderly, we project will rise from about 9% to 20% in the year 2040. Of that 20%, 9% will be on pensions and 10.5% of GDP on health care. We project that health care spending will rise from about 4% to 10.5%. Now, I thought it might be useful analytically just to decompose. Well, I'm not actually going to do a decomposition analysis, so don't get too concerned. But to just analytically identify the different components of this growth. The first component is simply the overall growth in the number of elderly. the rising elder share of the population. Why does that matter? It matters because per capita, the elderly consume a much higher level of healthcare services than younger adults do. Depending on the country, it's between 3 to 1 and 5 to 1. Actually, within public budgets at the federal level in the United States, it's 7 to 1. So the first component is the overall growth in the number of elderly. The second component is something demographers call the aging of the aged. The fastest growing elderly age groups will be the oldest elderly age groups. That the average age of the elderly themselves will be rising, and per capita healthcare spending at rates of disability and morbidity rise with age, even among the elderly themselves, and so does per capita healthcare spending, even among ascending elderly age brackets. Overall, the population aged 85 and over consumes about twice as much in healthcare services as the population aged 65 to 74. For nursing home care, that ratio is about 20 to 1. The third, and in some ways the most important component, is the fact that per capita, we're spending more on health care for everyone. Historically, per capita health costs, per age-adjusted capita health care costs have grown faster than per capita GDP in every developed country. The average for the developed countries is about 1% faster than per capita GDP. In the United States, it's been about 2% faster. So just analytically, that's what's driving the long-term growth in healthcare spending. Now, these are projections, of course. They're not predictions, and they show us where we'll end up if we don't change course. And obviously, they're wild cards in every projection scenario. And let me just very briefly, to wrap this up, identify 4 of them. The one is the future health of the elderly. These projections are based on constant age-related differentials in healthcare spending. But maybe the elderly of tomorrow will be healthier than today's elderly. There are 2 models, really, of aging and health. The one is called compression of morbidity. We all live to 105 and then die of a cold. Health spans rise with lifespans. The other is called failure of success, which predicts that actually we'll see a rising incidence of chronic morbidity at older ages in an aging population. So there's the health of the elderly. It's theoretically ambiguous and the empirical jury's out. We can talk more about that. The second is the potential for efficiency within the healthcare system. Many of you are probably familiar with Wenberg's pioneering work and small area studies, and just the vast the vast differences in utilization rates for different medical services between countries, between states, even within cities, between hospitals. There are really 2 views on efficiency. The one is that there's a vast amount of waste which can be eliminated through outcomes research. Then there's the other view that says that well, medicine is really, a probabilistic science, and there's no limit in theory to what we could usefully spend. There's technology, which historically is always added to costs, or almost always. Even when it's reduced per capita costs, it's generally added to aggregate costs. For instance, take something like lithotripsy. By decreasing the unpleasantness of medical procedures, you sort of induce new demand. So historically, technology has been a big cost driver. Maybe that'll change in the future. Maybe genetic medicine will change that. And finally, there are public attitudes towards rationing. Certainly, healthcare budget, the rising healthcare costs will put increasing pressure on public budgets, and governments will be looking for ways to limit healthcare consumption and to ration. Every economist will tell you that rationing is inevitable, that we have to do a cost-benefit analysis of different medical services. This reminds me of the joke about the two kinds of healthcare economists, and I'll conclude with this. There's the standing up kind, who says that we have to subject medicine to cost-benefit analysis and rigorous outcomes research, and ration scarce public resources. And then there's the lying down kind who looks up from his bed and says, "Hey doc, are you sure you've done everything you can?" So.
Right. It's the quick and the dead, huh? I'd like to come back to one of the wild cards that you mentioned, and those two models, the compression of morbidity model, the failure of success model, and you sort of posited them both as possible models. What's your sense of the likely, if I had to have you put a forecaster hat on, the likely direction that's going in 10 years, say?
There is considerable evidence that rates of disability are declining rapidly among the elderly in the United States and across a number of major developed economies. So are rates of residence in nursing homes. So the functional health of the elderly, especially the young elderly, in their late 60s and 70s, appears to be improving dramatically, which is very hopeful. And some researchers leap to the conclusion that means a compression of morbidity is underway. But of course, morbidity the disability isn't the same thing as morbidity. And the disability measures actually are very crude. They're of what are called activities of daily living. Can grandma dress herself? Can she cook for herself? Can she go to the bathroom herself? And in fact, at the same time as this decline in disability is underway, it appears that rates of morbidity are actually holding constant, or for certain conditions even rising among the elderly. So what may be happening is that grandma's getting around better, but she's getting around better because she's seeing the doctor more often. So the implications for future health care costs aren't necessarily clear. It may be that disability is declining precisely because we're spending an ever-rising real dollar amount per senior citizen on health care. So it's a mixed message. Certainly the improvement in the functional health of the elderly is a positive development and a very worthwhile goal. And it may, to get back to the point about the productivity of the elderly, really be the key to solving this whole long-term problem. But it doesn't mean that we're going to spend less on Medicare in the future.
Yeah. Michael, what are you seeing clinically in the field in this regard with your patient base?
The thought just came to my mind since just to ask Richard if, as you're postulating that compression of morbidities, if you will, are you seeing any change in the expenditures in the last year of life, which have been one of the major expenditures in healthcare? And if you're not changing the expenditures in the last year of life, you're just you're not changing the economics of the equation, you're just changing the time course.
Right. More broadly, if declining disability led to a moderation in the healthcare cost trend, and declining disability has been underway for the past 25 years in the United States, which it has been, then you would think that perhaps that moderation would show up in the historical data already, and it doesn't. On costs in the last year of life, I mean, that's an important point that you raise. Actually, of sort of the three components of the increase in expenditures, the two that are most certain, really, is that the overall increase in the number of elderly will lead to higher health care costs, and that rising per capita expenditures for everyone will, driven by technology, driven by social expectations about what constitutes good health, right? The one that's a bit in doubt is whether the aging of the aged really means rising healthcare costs in the future, because it seems that healthcare costs may be associated not with your age, but with distance from death.
Right. In other words, if you tell me that the bulk of my healthcare spending happens in those last 30 days, and I'm a good citizen, and I say, well, gee, I don't want to incur that social cost. As soon as you can tell me when that 30-day clock is running, then maybe I will be willing to make that decision. But it's a little like your economist.
Or if we can tell you that there's really nothing that we can do that's going to make any difference in that last 30 days.
Yes, a statement that many physicians are loath to let out across their lips.
Because all of our data currently are population-based, not individual-based.
That's right. Yeah, and your training is quite contrary to that.
That's right. To rephrase your point, just to emphasize it, when you tell people, gosh, we spend 35% of Medicare on people in their last 6 months of life, often the reaction is, well, gee, it should kind of be obvious where we should begin the rationing. But you don't know what the last 6 months are until the person is dead, right?
That's right. It's a clock that counts backwards, not
Exactly.
forwards. Yeah, thanks for that. That's a good point. Let me ask you one more question, because you were a little equivocal, I'd say, on the role of technology as a cost increaser, as a cost decreaser. And partly cost increaser, there are more heroic interventions out there. We tend to do them. Lithotripsy makes many more people eligible who wouldn't be candidates for surgery, but who are healthy enough to undergo that procedure, net cost increasing. At the same time, the potential for more efficiencies, diminished unnecessary surgeries with better imaging studies, being able, presumably with pharmacogenomics, better to target pharmaceutical interventions to people who will benefit from them rather than a broad spray on the population. Net, where do you think that shakes out?
Well, it's the $64,000 question,
isn't
it? I'm skeptical of the cost-saving potential of technology, medical technology, genetic technology, particularly as it interacts with social expectations about health and healthcare. Whereas healthcare used to mean, a visit, the doctor with his black bag, or a visit to the community hospital for an X-ray. It's now becoming a lifelong process of diagnostics and fine-tuning, of continual and increasingly customized intervention. And I see, my limited knowledge of genetic medicine, I see increasing the potential for that. I see us entering a world, literally, in which there's no extra dollar spent that might not have some potential benefit. But of course we can't, if you just go back to sort of your basic arithmetic for a minute, healthcare costs cannot indefinitely rise faster than GDP, right? Or it'll consume all of GDP. There has to be at least something left over to hold conferences like this.
Yes, and there's no, we in the United States get dinged a lot for, well, we're spending 15% of GDP on healthcare. Sweden is spending, what, 11?
Yeah, something like that.
10, 11%. Why? And gee, our health outcomes are actually worse than Sweden's. Isn't this inefficient? Well, there's no economic law that says that it has to stop at 15 or 20 or 25 or 30. It's really a societal consumption choice of where we want to put our resources relative to other things.
Are our health outcomes worse than Sweden's? Certainly, infant mortality or life expectancy at birth. But is that all we're buying with healthcare? Actually, we're at the bottom of the developed countries in life expectancy at birth, in part because infant mortality is high among certain segments of the population. We're about average in life expectancy at 65. You see where I'm going here, and we're in the top 2 or 3 in life expectancy at 85. So it's where you spend your money. Also, life expectancy isn't the only thing you're buying with healthcare. Now Sweden spends rather lavishly, actually, on healthcare, certainly compared to the UK and some other countries. But we're buying quality of life. Whether you get a hip replacement at age 65, which you don't get in the UK and you get automatically here, has no impact on the longevity statistics, but has a big impact on quality of life.
Yeah, it's a key point, and the way one WAG friend of mine put it, it's sort of the James Brown effect, that in some of the poorer countries in the world, really what healthcare is buying is decreases in mortality, and if you improve water safety or the food supply and healthcare, you get an increase in mortality. In other countries, say in the UK, you're really trying to avoid morbidity. And here in the United States, we're paying in healthcare a lot for quality of life, or I feel good, hence the James Brown effect. Michael?
I just wanted to ask Richard another question regarding technology. Do you think, I believe, preface that part of the reason that technology has not necessarily reduced healthcare cost is because we don't have a way of really assigning relative value to innovations that occur in healthcare. Me Too, with some putative slight improvement, can then be used and universally with no real indication that it's doing any better than anything else. So if we had some way of assigning relative value, it would seem to me that may help address that problem. And secondly, if we had some way of being able to predict whether or not this use of new technology is really important for a particular patient, instead of, again, just looking across populations. So if we had those two caveats, how would you think that picture might be a little different?
Yes, if we could assign a relative value, if we had some sort of workable cost-benefit analysis that might, ultimately come out of outcomes research, that could save vast amounts of money. Here, I just the impertinence to introduce some data into the conversation. Heart bypass operations per 100,000 people. Austria, in 1999, Austria 40, France 35, Germany 38, Greece 61, Italy 46, UK 41, United States 203. You can look procedure by procedure by procedure, whether it's heart bypass, angioplasty, lower back surgery. This whole, and it's not just variation, as I said before, between countries, but between doctors within the same city. So there's a huge potential, I think, and that really has to be where we go. But it's rationing. Because there are unlikely to be entirely useless medical procedures, right? It's all a question of how much you test.
No, I disagree with that. I definitely disagree with that. I have patients who come to me to do, say, arterial bypasses in their lower extremity, and they have an intact limb. They're not in danger of losing it. They would like to have something done to make them better, but there's not a reasonable outcome that I can predict for that patient. And I use this expression fairly frequently, which is just because something can be done doesn't mean it should be done. If it's, how much is this really limiting your quality of life? How important is it to you to risk what may make your situation worse by going through a procedure, et cetera? So I don't agree that we have a knee-jerk reaction in healthcare to just because we can do it, we do it.
But these are largely judgment calls that may differ from one physician.
Right, because we don't have a way of being able to be more precise than the quote, art or experience of healthcare.
Yeah.
Yes, but
go ahead, Jan. I was going to.
There is a way, and that is with quality control. Very active follow-up to use collected knowledge on the outcome of interventions or selection of patient groups. And I think this is something that we're going to have to do much more in the future. This is certainly one thing that in Sweden has been a major focus recently, to, in a more controlled way, collect data from the whole country, even down to data from individual physicians and their outcomes. Comparing clinics, comparing individual physicians within a clinic and the outcomes you get of a procedure, to understand what it is we're really doing and how to ensure that the therapy we're giving is optimal, really does raise the quality of life. And I think this is going to be the basis of rationing in the future.
Could you say some more about the situation in Sweden? You've heard our conversation here talking about the United States, about the high degree of autonomy that you know, for instance, a vascular surgeon enjoys, that can stay within the bounds of the Hippocratic oath and take Michael's position of, well, just because you can doesn't mean you should. And other docs equally ethically can say, oh, absolutely, we must. So with that situation, with the situation that you're aware of that we haven't really talked too much about, though, of third-party payment for medical services, disconnecting the consumers of those medical services from a lot of responsibility for the overall cost. That's a trend that seems to be shifting some. The lack of, until you reach Medicare eligibility and are covered by the government, the lack of really a social sense of of responsibility for the costs and outcomes of healthcare. Could you talk a little bit about the situation in Sweden and how that contrasts?
Mm. So in Sweden, it's the healthcare is financed by a regional authority that see that the resources are allocated within the bounds of what's available. And this means that if you take the example you had, the bypass figures that you were quoting, I certainly do not believe that there is anyone in Sweden that would not get a bypass if they really need it. But it's the system that decides who needs it, and not the patient that decides that this would be something I would be prepared to pay for. And I think that is an important choice, that regardless of how the system works, we do have limited resources. Even if you have a system in which there is the opportunity for people to buy what you think you need, it's still a limited resource. And I think that this is an issue that needs to be focused on more, and is something that is key to the escalating costs of healthcare. Britain, you mentioned, has an even lower percentage of GDP that one invests into healthcare. But there one has gone to an even more extreme, that it's a different body that decides how much should be used. And you get the situations that the hospitals have filled their quotas and can't accept any more patients for a certain period. So that's not a good system either. I think you have to have control where the healthcare is going to be carried out.
Yes, that's clear. Now, talk a little bit more, and you alluded to it in your opening remark about the opportunities for research that a socialized healthcare system opens up. Can you talk a little bit about how that is structured and how that works?
So if I take an example, rheumatoid arthritis, which is something that's very much in the press nowadays with the effects of some of the medicines used. Rheumatoid arthritis in Sweden has been focused to a number of regional centers as a specialized disease for the most part for the patient care. And this has resulted in the collection of data about these patients at a number of places that has gone together into a national database so that you have all the data about the patients that have been treated for rheumatoid arthritis, well, at least 90% of them. There's still the opportunity that a general practitioner can keep the patients with them. And you have then access to different registries, because the whole system is based on a personal identification number. This means that you can then correlate the data to various outcomes. So, for instance, smoking is a clear cause of rheumatoid arthritis. But when you start linking up different registries with some of the clinical data, you can see that smoking is very clearly connected to a genotype and certain markers that appear before the symptoms appear. So you can actually identify groups of patients that are at clear risk that it would be advisable that they cease smoking. There's many other reasons why they should, but I mean, that's one thing. Another thing is, for instance, some of the outcomes of a disease. Again, rheumatoid arthritis, there's an increased frequency of certain forms of cancer, mainly lymphoma, and there was indications that some of the therapies used perhaps increased this frequency of lymphoma, particularly the anti-TNF alpha drugs. But by using these databases, as well as some of the biobanks, the regional biobanks, so one can go back to serum samples from 10 years back, it was possible to then again link up into different groups and identify a stratified series of rheumatoid arthritis patients and show that the lymphoma frequency is independent of therapy. And I think this is, again, a very important possibility to be able to identify correlations between therapy or selection of patients so that one can focus the use of treatment in the future.
This is fascinating. The panel that went before lunch spent a lot of time bemoaning the state of the infrastructure in America, and some of the elements that you just talked about as a given are ones that we've been struggling for years to put in place. Biobanks, where we have properly consented and annotated tissue samples that are also linked to clinical records, so that we have the opportunity to make the kind of population and longitudinal analyses that you talk about. Just having the records in a standardized and electronic format, missing across much of the U.S. and certainly not standard from institution to institution.
That's actually the weakest point in Sweden as well, the electronic records, because there are just too many different varieties that don't interact with each other. Biobanks is very interesting. We had a new biobank law that came into effect at the beginning of 2003. So now all samples taken in healthcare that are stored more than 2 months have to be stored in a biobank. If there's informed consent, you have to have informed consent to store it, and then you can also select whether or not the sample should be available for future evaluation of healthcare, use in healthcare, or research. And a recent follow-up of this showed that 99.5% of the patients automatically agree that their sample should be available for the future use. There's exceptionally few that will drop out or something like that.
Yes. Well, your case linking smoking and rheumatoid arthritis and using these registries and databases for predictive purposes, I think is a perfect segue into talking about the Marsh field. And Michael, I'd like to invite you down to say a few words. Let's see.
I do interviews. I hire a postdoc student or a post-baccalaureate student each year. And
Can that be seen?
Can we
with the
turn
light?
this?
So that's just sort of the way
Is that visible?
I
Thanks.
care
And I
about
just
my
have a
position
couple
and
of slides,
not
but
random and not random.
this one is, there's been a email circulating around recently talking about the accidental deaths from physicians versus guns, pointing out that there are 700,000 physicians in the United States, the accidental annual deaths greater than 120,000, translating to accidental deaths per physician at about 0.171 versus 80 million owners of guns, where accidental gun deaths yearly are around 1,500 and therefore 0.000188 accidents per gun owner. Now, there are obviously some flaws in this reasoning, and that is that every gun owner doesn't aim at an individual every day and throughout the entire day as physicians do. But it has, it raised the issue, which is being raised over and over again, that there are too many accidental deaths or problems that occur in healthcare, and that is, and particularly in the area of medications, that's reached huge financial proportions, and currently estimates of about $177 billion a year. Now, if you look at some of the in my opinion, some of the drivers of the cost and mortality that's occurring in healthcare, one is clearly the complexity of healthcare. It has reached the state where information technology is critical to the accurate and adequate provision of healthcare. There's a huge, as we've already mentioned, lack of integration of healthcare data. Lack of electronic medical records is estimated about 12 to 14% of healthcare providers are actually using electronic medical records. Currently, that's rising, and we do have national attention to developing electronic medical records. But to have a system such as we do, where we have 400,000 patients that we see on an annual basis, and all of their data are linked electronically throughout the 41 different regional centers that we have, is something that is needed critically in the United States, primarily because we have a mobile society. And we have a lack of portability of our healthcare information. So if someone goes from doctor to doctor, they start all over again, in essence, with their entire healthcare history. That is a perfect setup for problems, particularly when you're in a complex healthcare environment. Next, we aren't able to predict outcome of any of the interventions that we have on a personal basis. We can only look at populations because all of our data are population generated. But we know that everyone doesn't fit in the majority of a population, and for those that don't, we are making recommendations on a regular basis that are not appropriate for them. That includes not only in substratification of diagnoses, to be very precise as to an individual diagnosis. It also involves their response to medications, not only from the standpoint of safety and avoiding adverse effects, but also from the standpoint of efficacy. It also affects their outcomes from procedures and the use of devices as well. And in addition to that, what is clearly needed, and I believe we're getting to the point where if we can appropriately utilize our healthcare data, we should have the ability to predict the prognosis for an individual's disease and their possibility of encumbering the most economically disastrous aspects of healthcare, and that's hospitalization or complications of therapy. This is a recent cartoon from the Detroit News, which is very appropriate, I think, of what happens in the treatment of patients with medications, and going through multiple different complications that can occur. And because we can't predict for an individual patient whether that's likely to be them that's involved in this entire mass of prescriptions to avoid complications, we're left with a situation of sort of take this medication, go home and call me in the morning, and tomorrow I'm either a hero or a goat, depending on how that patient responded over the evening. But there is some hope. These are data from looking at a population who were in a Coumadin clinic taking the drug Coumadin or warfarin. It's one of the more popular drugs that's used in the United States, and also one of the more dangerous because it has a very narrow therapeutic index. And that means that the difference between the amount of medication that you need for therapy and the amount of medication that will hurt you is very small. Warfarin is rat poison. It was developed to kill rats. Rats would eat it, they go away and bleed to death. And if you eat it, you can go away and bleed to death too. The difference is, however, it's very useful for avoiding thrombosis, and as a consequence, it's a very commonly used drug. But until now, we had no way of predicting the appropriate dose for any individual. So we gave it to you, we tried to monitor you closely, and hopefully hope that you responded well to it. But as you can see here, based on the alleles for the cytochrome P450 2C9 gene, which codes for the enzyme that metabolizes, is a major metabolizer of coumadin, depending on whether you're a star 1 homozygote and therefore are the wild type, or whether you have mutant alleles, determines what your ultimate dose of coumadin is going to be. And subsequently, we have actually prescribed coumadin based on other standards of appropriate therapy, plus adding genotype. And I think you can see in the individuals that are on the red line side of this page that out of the population, by being able to use genotype, you can more effectively predict the dose of these individuals than you can with other standard models. So in my mind, and to finish, how do we try to make this better? And these are not simple problems, but they're clear keys, and this is not novel to me. This is being called for uniformly, I think. One is an integrated portable electronic medical record. That's critical. We have to be able to mine those electronic medical records for personal predictive value. In other words, how to be better as far as predicting the specific diagnosis of an individual, how to use their diagnosis and their comorbidities, their family medical history, their medications, their laboratory values, et cetera, to be able to predict outcome, responses to therapy, et cetera, for those individuals. And how to take some of the tools that have been extremely helpful in being able to look at differences in populations, such as the machine learning tools, and begin to apply them to medicine so that we can pull out those populations that are going to respond differently and those individuals from those populations that will respond differently. And then based on those types of data, derive biomarkers. Those biomarkers can be genetic, proteins, standard metabolites, routine laboratory values, whatever, that augment to the mathematical analysis and allow us to predict outcomes for patients in the future. So those were just my comments.
Great, thank you, Michael. Jan mentioned the use of registries in Sweden. To what extent are you making use of registries in the Marshfield Clinic and more broadly in Wisconsin? Is that coming into some more common use?
We have sort of a giant registry. We have 1.2 million electronic medical records, and we've been collecting all of the healthcare events on our population for decades, so that as a consequence, the electronic medical record is very extensive in that regard. We have subsetted, if you will, certain areas of that record into different registries for specific diseases for ease of analysis, but our record goes through a data warehouse that allows us to parse and split the data as we need to for specific research purposes and questions.
Yeah.
And then along with that, we have collected recently from an epidemiological study area that we have of 80,000 individuals. We've now are up to better than 18,000 samples where we've collected for DNA, serum, and plasma, and the ability and willingness of that population to allow us to use their healthcare data and their biomarkers, if you will, for pharmacogenetic data and analysis and genetic basis of disease and population genetic studies.
A little Sweden right within the
Well,
Midwest.
Wisconsin is a lot of Sweden.
It is a lot of Sweden, it's true. I used to live there. I know very well. I'd like to open it now to the broader audience for your comments and questions to this group. If you could identify yourself, please.
Vince Vilker with NIST. I've noted perhaps a contradiction, but I would like Jan and Michael to maybe comment on my observation. On the one hand, I hear Sweden using its databasing and registering activities to establish a rationale for decision-making in appropriating healthcare resources. On the other hand, I hear Michael talking about the trends, the generic information that comes out of a population study is not very useful for prescribing health care to an individual patient. That looks to me like a contradiction in philosophy. Where do the two overlap, and what useful things can you pull out of this?
Well, all our knowledge is based on studies on larger groups, and the larger the population, the better. In order to extrapolate from a population to the individual, you have to define the parameters well enough to be able to apply that, so you can identify the individual within the range of the population. And generally, the parameters we use to correlate to studies are pretty broad. But the more parameters we put in, such as genetic markers, such as other biomarkers, or identifying subgroups of patient populations, the better we can extrapolate the population data to the individual. But the whole time it's going to be an extrapolation, and there are always going to be individuals that fall outside of the framework.
And I agree, it's a refinement. It's exactly the way I would have put it. It's a, you start, the population data give you a starting place, but the hope is, and I believe there's some important aspects to it that are critical, and that is that the better you can define the place of an individual within the population, the more you can hold them responsible for a part of their health care. If I can't tell you where you're going to respond to a particular therapy that I give you, and it's just sort of anybody's guess, and I don't know how your behavior affects your position in that population, I have real trouble holding you responsible for what happens. But if I do, and if I do understand that your behavior does affect your outcome in that process, and that you should respond to this therapy if you comply with the process, then I can start holding you responsible for part of this healthcare process, and that can have some economic consequences as well.
Fawn Hudkins, Ethology News. You haven't commented on the difference between men and women or the difference among races. Is there anything significant?
I think there's some differences between men and women, yes.
Actually, this is a very important issue, because a lot of our medicine is based on studies on men. And outcome of heart disease is a typical example where a lot of the diagnostics, the therapies we use are established very much on studies on men and are extrapolated to women. But it's very clear that there are different pathologies, different response to therapy in women compared to men. So that we really need to broaden our view on many areas of medicine and include gender effects. The biological gender effects play a more important role than I think we have accepted previously.
And I agree, there clearly are gender effects, and as particularly as we're finding in pharmacogenetics and the like, important ones, as Jan has pointed out. And in addition, I think that we're finding in some cases less than we would have predicted ethnic effects and differences in these responses. But all has to be part of the equation, because in certain instances they're very specific mutations and the like that aren't seen across all ethnic groups.
Hi, Joyelle Mulheron, American Cancer Society. Going back to assigning relative values to medical advancements, I'm wondering how would you start to assess and what factors would you use to look at the taxpayer's return on investment to medical research?
That sounds like your question.
Well, I guess the big elephant in the boudoir there is whether age should be part of the equation or not. I mean, obviously, you want to look at probability of survival. You look at, but should you explicitly take into account the fact that saving the life of a child or restoring a child to health and function has a long-term return for the economy, and restoring a 70-year-old or an 80-year-old has a much smaller return. I'm not God. I don't have the answer to those questions. That has to be a very broad societal debate. But I think the big one there is age. And I guess there's another issue we haven't discussed, which seems to me one of the big questions as we look forward in the future is really the impact of our genetic knowledge. So we now have we can peer into our future. It has a huge impact on sort of the insurability of people. I mean, do we take into account when we're thinking of whether to treat somebody for a condition now that we already know they're going to fall victim to some condition further down the road predicted by their genetic markers?
Well,
how do we deal with that?
Let me try to answer the initial question and try to address that. And I'm not sure I can answer either one, but the initial question, I think, comes to a large extent in a redefinition of efficacy. Let's say in the case of medications or that type of therapy or other types of therapy. We have traditionally defined whether or not something is effective, but not necessarily how much more effective it is than something else that we're currently doing. And there's a gradation there that is related to value. If it's equally as effective and safe in our country, it can be used, and it becomes a marketing issue as to whether or not it gets utilized. So the key would be, in my mind, assigning some value to efficacy, to increased efficacy, if you will, and that value I think would be really important. The second one, regarding the insurability, if that question is already one of the ones that plagues genetic work and the development of genetic diagnostic tests and the like in this country, is because many individuals are concerned that their insurers or their employers will get a hold of that information and somehow will discriminate against them either in their employment or in their insurability. Unless that's addressed, which by and large has to be addressed nationwide. It's addressed in Wisconsin, but if you move out of Wisconsin, it's not addressed necessarily. Unless that's addressed, we're not going to see any of this because it'll never get off the dime because of the concern and the fear that individuals have as to discrimination in that regard. So that has to be addressed, and that lack of discrimination. Then you raise, I think, another issue which gets into the ethics of healthcare, which is if you know someone is going to, has a much shortened lifespan, do they somehow deserve less health care in the early part of their lifespan than someone else? I guess I would say that's an ethical issue, and hopefully never get to be an economic issue, but it might.
I think in most societies that would not be accepted. And it gets back again to the
I would hope
question
not.
you asked originally about extrapolating from the population to the individual, we're still talking about probabilities all the time. Even when you start looking at genetic markers, I mean, it's still probabilities. And to say that a certain descriptor is 100% related to something for an individual is impossible.
Probably never.
So, I mean, you could never do that sort of selection.
Jan, coming back to that initial question about measuring research efficiency or research impact societally, to what extent is that done in Sweden, or if not for research, at least for various options for medical practice?
That really is the function of the quality registers, to be able to follow up whether or not an intervention gives a better result. And that, how you describe that has to be related to the specific therapy or the specific disease you're looking at, and what descriptors you put in as a measure of outcome in different ways. And I don't think it's possible to do that on a broad basis. You have to do it case by case.
Yes, and so if case by case the evidence turns up one intervention as clearly being more effective and cost effective than another, are there mechanisms within Swedish medical practice to enforce that practice, that everybody practice more uniformly?
So there are usually regional, either national or regional health plans for specific diseases that take these factors into account. So if there are clear differences, then I mean, it would be unethical not to use the most effective therapy. There are also, for instance, drug lists that steer the choice of drugs in certain issues. This has become a major issue with some of the drug companies, particularly the Swedish drug companies, where they claim or insist that they're investing so much into society, they should have a better opportunity to get back from society by selection of their drugs. But it comes down to the various aspects of rationing and how one ensures that the resources that are available are used in the most optimal way, and ensure that the patients get the best outcome from what they are trusting on.
We had one state governor and legislature in the 90s that were very courageous in that regard, in the state of Oregon, which prioritized various medical interventions in terms of perception of social benefit, and below a certain line, when the money ran out, and those less valuable or perceived as less valuable procedures didn't get done.
Hi, Alan Herbert, Boston University. Just more or less a comment about the cost effectiveness of technology, and sometimes it's better to form an opinion by looking back than looking forward. Like, for example, in the 30s in tuberculosis, if you built a sanatorium, you would have gone straight out of business once the antibiotics came around. You know, something was really expensive became cost effective. Right. The same with people used to summer in New Hampshire because they had asthma, and then a nebulizer came along. Same with like peptic ulceration. Initially you used to have your whole stomach cut out, then part of your stomach, then a few of your nerves, then you would take cimetidine, now you take an antibiotic. So, you know, technology tends to be a little disruptive, but the trend is that it tends to be eventually get there, even though it goes through some reiterations, like bypass surgery would be an example compared to use of stents. You know, but the trend is that it tends to factor the cost down eventually.
Well, I'm not. I actually, ulcers is is a good example of an exception to the rule, I think. I'm not sure that you're right. It's important, first of all, to make a distinction, right? I think epidemiologists, if that's, or historians of a disease and morbidity make a distinction between conditions for which medicine finds a cure. The typical infectious diseases of the earlier era, and the kinds of chronic conditions, much more complex conditions that drive most morbidity today, that have cancer, heart disease, that have complex genetic and behavioral and environmental causes. And ordinarily we're dealing with what are called halfway technologies, which generally tend to be more expensive. Of course, if it turns out that ulcers are the result of, what are they the result of in the end?
H. pylori.
H. pylori.
Right, exactly. I'm not saying you're wrong, but I'm saying it's not the rule. And if it was the rule, we'd be spending less today than we were before, and we're not.
These technologies aren't predictable before they develop, and
Yes, you're right.
you're just factoring in the fact that things are the way they are, but there are potential technologies out there that could be more than halfway houses. You know, actually, one of the problems with studying bone density nowadays is there's one drug out there that's really effective at preventing osteoporosis,
Yes.
and that's a complex disease. It's gone. It's not a medical trait per se anymore.
Well, I completely agree. I mean, that's what I came here hoping to learn, that we'd have a pill someday soon that would cure all types of cancer.
But there are technologies.
I agree with you.
There are technologies where there is clear possibility of following up and eliminating or improving. One example is preoperative EKG on a apparently healthy patient, which has been routine in most places, just to make sure. It has been shown in follow-up studies to have absolutely no benefit at all. But it's when you look at the total cost, it's quite a lot of money that you put into a preoperative EKG. And just by removing that, I mean, that's a good way of steering resources to something that's better.
Joanne Carroll from St. John's University. I was just wondering if you could comment on the cost of the uninsured populations who access healthcare at a much later point in time, and therefore not having good basic universal healthcare in the United States. Is that not contributing to a very high amount of the cost, and should that not be addressed before we discuss rationing?
Well, I think that the main problem with the uninsured population is, as you pointed out, is healthcare later rather than sooner, and often in an inappropriate setting. Overall, the uninsured do consume fewer healthcare services and cost less. But I'm not suggesting that the solution to our healthcare cost crisis is depriving everybody of health insurance. I think I don't think that's a cost driver, though. You know, obviously, a trip to the emergency room to end up taking an aspirin when you should have seen your primary care physician does add on a case-by-case basis to cost. But overall, the uninsured aren't driving healthcare costs. At least not in the data I'm familiar with. Because the lack of insurance really does lead to lower consumption of healthcare services. Though when they end up consuming... Right.
We have time just for one more question.
No, I think her question was that by delaying health, let's say maintenance, by delaying health maintenance, that then there's an incremental expense that occurs later in life.
Yes, there is. That ends up offsetting some, but not all, of the lower expenditure early on. But I think the main problem is just a poorer health outcome.
Have universal health care really make any difference in terms of cost, reducing the cost of overall health care in the United States?
It depends on how the universal health care was paid for. You know, would we have a global budget on health care, which every other country has in one form or another, and we don't? I mean, I'm not sure I know the answer to your question. Given the current financing mechanisms, no, it would increase expenditure.
I would say, from my point of view, yes, it would reduce the cost by bringing in healthcare interventions at an appropriate stage.
Yes, and the conversation so far hasn't said anything about the ethics of limiting costs by limiting access.
Would you comment on the difference between mental illness and physical illnesses and how it affects what you're talking about?
Would I comment on that? How that affects which which dimension of
He's saying we don't have parity in insurance between mental and physical health. Yeah.
right. Well, maybe I'm on the wrong side of this one too, but I think if we did have parity, we'd probably, although in some cases, we would have appropriate interventions earlier and hence would save money, that in the aggregate we'd spend vastly more, that the lack of parity and the lack of coverage probably decreases consumption in the aggregate. Whether that's a good thing or not in terms of health outcomes is another question, but in terms of costs, I'm relatively confident that lack of insurance coverage decreases healthcare consumption.
I mean, think about it. There's 300 of us, which sounds like a lot, but there's like 4,000 post offices.
I'm not quite sure what the question is. So you're asking if there's any difference in the way in which mental health is coped for in comparison with physical health?
Yes, in the United States, our health insurance coverage for mental health services is much more limited than our health insurance coverage for physical ailments, and so many mental illnesses end up going undiagnosed or untreated in time, or to jail or on the street. Yes.
Okay. This is something that's a big problem and an increasing problem in most developed countries, that mental health problems are increasing. There are many factors that are involved here. One is that we don't have really good diagnostic parameters such as you do for a physical condition. It's much more difficult to diagnose a mental condition than it is with a physical condition. You can't just take a sample and see what the problem is. Another issue is that in many societies this still has a lower priority than in others. And I would say that this is true in a lot of European countries, that it's even if it's not something that is stated, it's something that it happens in fact. And I would say the same in Sweden, that mental health is not as well taken care of as physical health is, because of a number of reasons. There aren't the drivers in some cases. And these are patients also that are not so readily accessible in many instances. There are a number of issues that result in a poorer mental health care than physical health care. But it's not the insurance or the availability of health care that I think that is the causative factor in Sweden. It's other issues that need to be addressed within the society.
Panel, I'd like to ask you a closing question, and coming back to the where you sit determines where you stand. I'm expecting some fairly divergent answers, which is, if you think out 5 years from now, I'm asking you to put a forecaster's hat on, and to think about the impacts of genetics in health and in medicine. If you had to point to a single impact that you think would be the most significant, say 5 years out, what would that be? Jan?
I think the key issue is going to be a very active long-term follow-up of our patients, and that includes genetic markers, so that as soon as you introduce a drug therapy, there has to be a long-term follow-up, because we know the complexity is much greater than the rather simplistic systems that we've had for selecting both therapies and patients.
Richard, I know that's an unfair question to a demographer, but...
Well, complete ignorance is never a reason not to venture an opinion. so I'll venture one. I think that the remarkable and accelerating advance in genetic medicine is likely to push us, if not over the next 5 years, certainly within the next 10, into a position where we have to face more explicitly some of these rationing choices that we were that we're so far have been able to sidestep, at least in the United States. So that would be my prediction.
Thanks. Michael?
I think pharmacogenetics and pharmacogenomics is a no-brainer in the next 5 years. We will have much better understanding of genetic basis of patients, individual patients, handling of medications. I think we'll actually see mandated genetic tests for the use of medications, many medications, particularly dangerous medications in the future. I think subsetting diagnoses, stratifying diagnoses, so that we're better able to treat subsets of particular groups. All asthma is not the same, et cetera. And if I can take the term rationing and tweak it a little, I think what we will begin to do is get a little bit better idea about where types of therapies are useful in certain individuals and where they're not. And so it's not denying someone perhaps health care, it's, in my mind, giving them more appropriate health care. And I think that's a little further down the line because it gets into efficacy, which is going to be a longer picture. But safety early in the next 5 years, I think we're going to see a lot of.
Good. Well, thank you all very much, panel, for a job well done. Let me tell you, before I ask you to thank the panel, that beginning at 3:30, we will have the fourth in the Genetic Age panel series that is going to be focused on policy, regulation, and genetics. The conversation that we began here that had to do with insurance and insurability, I anticipate, given that we'll have 3 medical ethicists on the panel, will be continued in an interesting way at 3:30. So please join me in thanking our panel.